Hi, this is Tim Weber from South Texas College, coming to you with another lecture video. This time, the topic is going to be late adulthood, and we'll get a bit of an introduction to that. This video will be followed by a couple more to complete the topic. Notice that we're going to be focusing on physical and cognitive development in this chapter. So we'll be taking up topics such as ageism, health and sickness, thinking in late adulthood, also the aging brain, that changes, and then sort of what is typical in terms of information processing amongst people over age 65. Then looking at also those who are somewhat more impaired and neurocognitive disorders. We'll also be looking at optimal cognition, new cognitive development amongst people in late adulthood. So those are topics you'll be seeing throughout these lectures. Okay, so let's go ahead and then delve into, here we go, the topic of ageism. So ageism is a form of prejudice where we are stereotyping people simply on the basis of age. And so in terms of the elderly, then we're looking at stereotypes that might involve the idea that uh, people are impaired in their abilities, in terms of sensory abilities, in terms of uh, movement abilities, motor abilities, and the idea that people in late adulthood also are impaired in terms of their cognition and ability to process information. So those are some stereotypes that abound about people who are older, and these are not necessarily true of everyone in late adulthood. Some people may experience these things, others may not. So notice we're simply applying those ideas to every individual, regardless of their actual situation. So, one of the manifestations of ageism would be what they sometimes call elder speak. It's kind of a weird word. I don't like to use it, but, this would be sort of when we talk to older people and you may see people talking to them as if they're talking to a small child, so they're speaking slowly and using simple, very simple language, repeating things, speaking loudly in a high-pitched voice, almost as if they're speaking to a child. And this is sort of a condescending sort of approach to the older person. That older person's response may be irritation, finding it irritating, or this can also produce a sense of self-doubt in the older person. Irritation may be in that, hey, I'm not that far gone that you need to speak to me that way. I can hear you just fine, and I can process what you're saying. That can be irritating. Self-doubt may be, oh, do I seem to be that far gone? Is it apparent that I'm slipping? So either way, this is not generally helpful. Now, you might ask the question, well, then how should we speak to that older person? And I would suggest that what you do is you approach them and speak to them just like you would anyone else. And you might ask them a question or two to see how they respond. And if they respond in an appropriate way, you don't have to speak more loudly. You don't have to make it simpler, that they can hear you and comprehend it just fine. So you might gauge it that way rather than starting out and speaking in this other way. So stereotype threat also influences the older adult, or can, and this is due to anxiety about being judged prejudicially. Um, in some cases, the older person may try to counter all that by doing things to try to appear younger. So they might maybe dress in clothes that don't really seem appropriate for their age, like dressing like a teenager, or they might try to move around real fast so that it appears that they're not uh, impaired, trying to sort of counter those stereotypes. Well, that's not all bad, I suppose, with the clothing, but yeah, maybe sometimes that can actually be a bit dangerous if they're trying to move around so fast that they're prone to accidents and so on, or trying to engage in activities that they shouldn't be doing anymore. So that can sort of be dangerous. But the other thing has to do, again, with sort of the anxiety produced by prejudice beliefs. One of the things that illustrated this was a study done by Levy and Langer some years ago, and they compared memory ability of Americans who could hear. These are all elderly people, elderly Americans who could hear, deaf elderly Americans, and then Chinese elderly individuals as well. What they found out is the memory was best amongst the Chinese, and amongst Americans who had the best memory, it was those Americans who were deaf. And you might think, well, why is that? What does this seem to point up? Why is it that Americans, elderly people who could hear well, why did they actually show more impairment of memory? And the interpretation of it was that, well, uh, the Chinese, they hold the elderly with great respect. They don't think of the elderly as being impaired in their memory ability, thinking of them as being, wise and so forth. So there was not the anxiety about memory loss within that group. It was not part of their stereotype. Amongst the Americans, why did the deaf people uh, have better memory? Well, they hadn't heard over and over again people saying, oh, when you get old, your memory's going to go on you. They hadn't had that input, and so they were less affected by that stereotype. Those who could hear had heard this over and over again and were more influenced by that stereotype. So ageism then can be a detrimental influence on the elderly person. Also, ageism may prevent the elderly from seeking needed help. So let's say that that grandpa really needs some tools to help him with his walking, and so the doctor prescribes a walker. But he says, "Hell no, I'm not doing that because if people see me using that thing, they're going to think I'm old and they're going to treat me like I'm old, and I'm just not going to use it. I'll take the chance of falling." Yeah, so um, this whole business of stereotyping older people and treating them in accordingly can be very detrimental. Now, let's have a look at demographics and population patterns that have an influence on our treatment of the elderly. So traditionally, populations were pyramid shaped by age. In other words, you had a pyramid where the bottom layer, made up of children, was very large. And then you had a middle segment of that pyramid, somewhat smaller, made up of adults. And then finally, you had just the tip of the pyramid, a much smaller group being the elderly, people in late adulthood. So this occurred because children were born at the replacement rate, enough children to replace the adults and elderly that were passing away. Um, that said, half of children died before age 5 due to um, lack of sanitation and nutrition. So we're looking at here in America some years ago before those things had improved. That pyramid then stayed pyramid shaped because you had adults who in middle age would die of things like cancer and heart attacks and not survive that. So as you went up the pyramid, it narrowed, fewer people as you got older. Now, in developed nations, we already have moved to sort of a square pattern where now we're having as many elderly, almost as many elderly as adults, as children. And in fact, that square pattern could invert itself into an inverted pyramid. That ratio could flip, where we have actually more elderly than other adults and far more elderly than children. How could that flip? Well, if baby boomers live to age 100 or somewhere thereabouts, if that becomes more common, if emerging adults are not self sufficient by age 25, if we continue to have fewer children per couple, that could happen. Okay, now that then brings up the question of, well, who's gonna care for that growing number of elderly people if that occurs? So there's some good news when it comes to answering that question. When we look at the dependency ratio of people in late adulthood, this is the number of elderly people who are self-sufficient and can take care of themselves versus those who are dependent on others for care. In developed nations, we've got a ratio of about 2 to 1, and that's better than it's ever been. So, yes, more people in this age group can take care of themselves than need care. So they don't all need someone to take care of them. That's one thing we should recognize. Secondly, the answer to the question, are the elderly primarily caregivers or care receivers? You might be surprised to find out that older adults actually provide more hours of caregiving than the rest of the population, caring for others. So they may be actually caring for other older adults in many cases. And in terms of what the elderly contribute to society, consider they're more likely than younger adults to vote, to pray for others, participate in civic groups, donate time and money. So they're really contributing a lot to society. But in fact, in many cases, they also, within that group, will be able to provide care for others. Now, also consider that those that need ongoing care are primarily the oldest old. Those are the people, age 85 and up. That's where you're most likely to see people needing ongoing care. Not so much that group between 65 and 85. In fact, if you look at it, even including the oldest old, notice this: only about 4% of the over 65 age population are in nursing homes or hospitals. Does that surprise you? You might have the idea that it was far higher than that. That's about where it's actually at. So, one of the things that has helped to even those statistics is that we have people who are suffering from debilitating illnesses for fewer years now than in the past. So this is called the compression of morbidity, where people spend less time being ill or infirm before dying. This has mostly been done by postponing debilitating illnesses, staving them off for longer. Now, what has enabled us to do that? For one thing, understanding that lifestyle is important for maintaining health. So, getting people to quit smoking or get exercise, so on. Some people have actually paid attention to all that, and it's showing in that. Also, developments in medicine and technological aids also that can help postpone illness as well. Now, having said that, there are a lot of chronic, uh, not immediately debilitating conditions that older people may have for many years. So they might be dealing with things like arthritis, maybe high blood pressure, and so on for many years. But in fact, in many cases, we now have ways that people can still continue to function in spite of those things and before they become debilitating. One of the things also that's been very important, as you see in the picture over here, would be preventative medicine. And so regular health checks that can identify problems early so that steps can be taken to reduce problems with those things. So, kind of the upshot of this is most people living in North America who live to be age 95 likely to be independent for almost all of those years, maybe spending only a short time being dependent on others, or maybe in cases, some cases, none. Now, we do have elements of aging that are very common, and that includes sensory deficits. So, the impairment of vision, hearing, and so forth. So, yeah, some elements of aging are inevitable, they're just built in to the organism. Of course, that apparent just changes in appearance. Do what you may, you're going to have wrinkles that eventually develop. The body shape is going to change somewhat. We might be able to stave off some of that with exercise and various sorts of therapies. But all in all, those things will begin to show up. And as time goes on, older people do experience some decline in all of the sensory systems. For example, only 10% of people age 65 and up can see well without glasses. So, most people age 65 and up will need some visual correction, maybe not glasses, but some way of doing so. By age 90, the average man loses 80% of their hearing. And so, once again, um, you know, those things are pretty common. Now, that said, use of various types of aids can help compensate for loss. So, hearing aids, properly fitted glasses, things like that. So, in the picture, you see an elderly man, and it's been his custom to read the newspaper daily. And as his vision has been impaired, he's found a way to continue to do that. Once his glasses were not sufficient, adding a magnifying glass enabled him to continue reading. And it looks like large print there too, right? So there are aids then that help the person to continue to function in spite of those sensory deficits. So here are some visual impairments most common amongst the elderly. We have cataracts. And this is where the lens of the eye thickens, becomes cloudy, and this distorts vision, causes things to be fuzzy, and so on. Cataracts can be relieved with various types of surgery if they are sufficiently problematic. Glaucoma is another one. This is caused by a buildup of fluid within the eye, too much interocular pressure, which begins to damage the optic nerve. This is the damage to the optic nerve is pretty much permanent as far as I know. This causes the visual field to narrow, and so people get sort of tunnel vision. Their peripheral vision is impaired, so they don't see things at the sides as they would have before. This is one that creeps up on people. If they have not had this checked, they may have high pressure within their eye and not know it. So if they detect it early, they can slow the progress of it using eye drops. There may be surgeries also that can do this if it's more severe. And oh, by the way, yeah, more common with people with diabetes. You might want to be aware of that since we have so much diabetes in the valley. Macular degeneration. This is one where the retina, that sheet of tissue at the back of the eyeball that contains our photoreceptors, begins to deteriorate, and the degeneration is in various areas of the visual field. And so one of the first indications of this, if not caught in an eye exam, might be that the person in reading misses letters of words or maybe misses entire words as they read. This is progressive. Um, there are now medications that can, again, slow the progress of macular degeneration that can be used if it's caught early enough. So just to give you a sense of what that does with people's vision, A here is supposed to represent kind of just normal vision. What we see here in B is what happens as people develop cataracts and everything becomes fuzzy and blurry. What you see in C would be sort of trying to show you what goes on with glaucoma and the peripheral vision being impaired, sort of a tunnel vision sort of thing developing. And then macular degeneration in D, that's for a pretty large area of the visual field being covered by that degenerative area. But you might see that in other spots, other parts of the visual field. So it's important that people, as they get older, do have their eyes checked regularly to kind of catch these things should they begin to develop early. Okay, so when we're looking at aging, then we can distinguish somewhat between what we call primary and secondary aging. So primary aging is the universal, irreversible physical changes that occur in all living things as they get older. So this is just what is built into the system. Um, this is something that everybody then experiences. Okay. Secondary aging are changes that become more common with aging, but result from poor health habits, maybe combined with genetic vulnerabilities and other influences that vary from person to person. So, what we're saying here, these are changes that do become more common as people get older, but not everybody experiences all of these. And a lot of it has to do with the person's environment and how it interacts with their genetic type. So, secondary aging then includes things like cardiovascular disease. So, studies of this indicate that yes, a type of secondary aging because not everybody gets it. Although the older you get, the greater likelihood of it appearing. And there are factors then, lifestyle factors, that influence whether it develops. Again, interacting with genetic vulnerabilities. So for many years, we've known about these risk factors, going back to Fried and others back in 1998, identified 6 risk factors for cardiovascular disease. Oh, by the way, I should mention cardiovascular disease, disease of the heart and blood vessels, in case you were wondering. So what are those risk factors which all become more common with age? Diabetes, either type 1 or type 2, either type of diabetes. Smoking, visceral fat, in other words, storing fat around the internal organs and the middle part of your body, the abdominal area. Um, High blood pressure, lack of exercise, high cholesterol levels. Okay, so have a look at that. How many of these things can a person do something about? You say, well, if you got type 1 diabetes, can you do anything about it? Well, you have it. Okay, yeah, that's true. But if you manage your blood sugar as best as you can, you're going to find that managing that diabetes lowers your risk of cardiovascular disease. Type 2 diabetes, interestingly, in some cases can actually be reversed by lifestyle changes, such as usually involves significant lifestyle changes, but what? Being very careful about one's diet, getting regular exercise, making sure to get enough sleep. Here's something that we can do something about. Okay. Smoking, obviously, again, something that is voluntary. And you can say, well, some people get addicted. Yes. But even people who are highly addicted to nicotine can quit. Now, it does often require a lot of perseverance. I think the average is the person who actually quits once and for all usually has, I think the average number of tries to quit is about 6. So it's, yeah, trying to quit once or twice often is not enough, but if they're persistent and keep trying to quit smoking, eventually they can overcome it. And of course, there are programs and aids for helping people quit smoking nowadays as well. So also the accumulation of visceral fat. So we can influence that by keeping the body weight within a reasonable range, doing exercise, especially exercise that builds muscle, that helps us to prevent putting on so much fat, and of course, eating right. Even those who are predisposed to storing more fat in that area, if they keep those things in line, they can make great improvements on that. High blood pressure. Yeah, that's one. Again, we can do something about that. Again, sometimes dietary changes, changes in body weight and exercise are enough to bring high blood pressure down. In other cases, people may need to take a medication to keep it in check. But one of the important things is just what? Detecting that that blood pressure is out of line. And so people should, have that checked regularly to catch that if that's happening. Then we have also lack of exercise. Once again, something we can do something about. And say, well, maybe older people can't exercise as readily as younger people. That may be true. They may have some injuries, they may have some weakness that has developed, and so forth. But often, that older person can develop their physical capacity to a great degree if they are, again, persistent, and if they maybe have some assistance in coming up with an approach that works for them. So that's important. And then high cholesterol. Now, this one, they have subsequently learned that it's probably certain types of cholesterol and certain profiles of high and low density cholesterol, and even subtypes within that that are contained within that risk of high cholesterol. So that one is maybe a little bit more complicated than just looking at the person's overall cholesterol number, but there are some cholesterol patterns that definitely do raise risk. These often can be modified again through lifestyle. If that's not sufficient, then medications are available that bring that more in line. Okay, so we've taken it that far. We're going to stop now and we'll continue the lecture then on a subsequent video. So thanks for listening and hope you're having a great day. And that's it.